This patient is a 55-year-old female with unexplained syncope, prior myocardial infarction, and ejection fraction of 45%. A diagnostic electrophysiology study was requested to determine if ventricular tachycardia could be induced and help decide whether an ICD should be implanted. After informed consent is obtained, the patient is brought into the electrophysiology laboratory and 2 sets of defibrillation patches, grounding pads, ECG leads, blood pressure cuff, oxygen saturation monitor are applied. The patient is then prepped in the standard fashion. Here we are entering only from the femoral vein, so bilateral groins are prepped. Some operators may choose to access the internal jugular or subclavian veins as well. After prepping the areas for venous access, sterile draping is applied. The operator performs a sterile scrub and dons a sterile gown and gloves. The equipment needed for the procedure should be immediately available, including a local anesthetic such as lidocaine with needles and syringes, introducer sheaths of varying sizes with sterile tubing, catheters, and associated cables. The recording system, pacing stimulator, and fluoroscopy are also needed. To obtain venous access, first feel for the femoral artery, which then identifies the location of the femoral vein about 1 centimeter medial to the artery. Local anesthetic over the femoral vein is given. Conscious sedation may be used, but general anesthesia also may be needed at times, as determined by physician and patient preference. After adequate local anesthesia has been achieved, the femoral vein is accessed using the modified Seldinger technique. Ultrasound guidance may be desired for venous access because it allows entering only the anterior wall of the vessel, reducing the likelihood of post-procedural hematoma. A wire is placed through the needle once there is blood return. Between 1 and 3 access points are obtained. Here, 2 more venous access points are obtained in the femoral vein, about 3 to 5 millimeters apart. After the wires are placed in the veins, the sheaths are inserted over the wires. Once venous access is obtained, the electrophysiology catheters are inserted through the sheaths. Under fluoroscopy, a quadrupolar catheter is advanced into the right ventricular apex. A second catheter is placed in the His bundle position. The third catheter is placed in the lateral right atrium. The recording system should be set up with ECG leads on top, the high right atrial catheter next, then the His catheter, and then the right ventricular catheter on the bottom. The His catheter demonstrates atrial signal, seen by the yellow arrow, the His bundle potential, seen by the red arrow, and ventricular signal, seen by the blue arrow. After pacing thresholds are checked, programmed ventricular stimulation is completed to determine if ventricular tachycardia can be induced. Using the pacing stimulator, single ventricular extra stimuli are delivered. A pacing train of 8 beats is given at a fixed cycle length, and a single extra stimulus, also called S2, is given as the 9th beat. Since the baseline cycle length is 590 milliseconds, 500 milliseconds was used for the pacing drive, and the single extra stimulus was given at 450 milliseconds. The timing of the extra stimulus is decreased by 10 milliseconds and repeated. The S2 is decreased each time by 10 milliseconds until there is no longer ventricular capture, as evidenced by a pacing spike with no QRS complex, also called the effective refractory period, or ERP. Here, the ERP is 220 milliseconds. A second pacing train is then given at a different cycle length with a single extra stimulus. 400 milliseconds was used for the pacing drive and 350 milliseconds for the extra stimulus. Again, the extra stimulus was decreased each time by 10 milliseconds until ERP, or 210 milliseconds in this case. Double extra stimuli were then delivered. A drivetrain of 500 milliseconds was delivered for 8 beats, followed by 2 extra stimuli. The first and second extra stimulus are given 30 milliseconds above the ERP, found during single extra stimuli testing, or 250 milliseconds here. The second extra stimulus, also called S3, is decreased by 10 milliseconds. The S3 is decreased until capture is lost, or to a lower limit of 180 to 200 milliseconds. Very tight extra stimuli are more likely to induce ventricular fibrillation. If this lower limit is reached or capture is lost, the S2 is then decreased by 10 milliseconds and S3 increased by 10 milliseconds. S3 is decreased again until capture is lost or the lower limit is reached, and then the S2 is decreased again until capture is lost or the lower limit is reached. Here, at a drive of 500 milliseconds, S2 of 210 and S3 of 200, there is loss of capture of S2. This process is then repeated at the pacing drivetrain of 400 milliseconds, with the S2 and S3 30 milliseconds above ERP, or 240 milliseconds in this case. Again, the S3 is decreased by 10 milliseconds until loss of capture or the lower limit is reached. The process of decreasing S2 and S3 is repeated until capture is lost with S2. Triple extra stimuli are then completed. A pacing train of 500 milliseconds is then given, followed by 3 extra stimuli, all given 30 milliseconds greater than the ERP, or 250 milliseconds in this case. The third extra stimulus, or S4, is decreased by 10 milliseconds until loss of capture, or the lower limit is reached. At that point, the S4 is increased by 10 milliseconds and S3 is decreased by 10 milliseconds. The process of decreasing extra stimuli is completed until S3 loses capture, and the S4 decreased by 10 millisecond increments. The process of decreasing the extra stimuli continues until S2 loses capture. Triple extra stimuli are repeated with the second drivetrain of 400 milliseconds until S2 loses capture. The right ventricular catheter is then moved to the right ventricular outflow tract, and the whole process of single, double, and triple extra stimuli is completed. Some operators may choose to repeat up to triple extra stimuli from the right ventricular apex and outflow tract while on isoproterenol. If monomorphic ventricular tachycardia is induced, as seen here, the test is considered positive. A defibrillator should be charged, but overdrive pacing to terminate the rhythm should be attempted first. Overdrive pacing was not successful in terminating VT in this case. A shock should only be completed if the patient is hemodynamically unstable. If ventricular fibrillation or polymorphic ventricular tachycardia is induced, it is a nonspecific finding for deciding whether to implant an ICD. If monomorphic VT is not induced, the electrophysiology study is considered negative. Once the study is finished, the catheters are removed from the body. The sheaths can then be removed with manual hemostasis obtained. It is important not to bend the legs for 4 to 6 hours after sheath removal to prevent the development of hematoma. The procedure is then complete.